University of Hong Kong, and he is a prolific surgeon. I've seen him operate, as also the fact that he is a very good speaker, and he is going to give us an introduction to whether it's safe to travel with intraocular gas. I mean, I think it's a very important subject, and we would love to hear your comments.
Thank you, and thank you for the opportunity. I'm a retinal surgeon, so I create glaucoma.
Yeah.
So I think that's the reason why I'm in this session. So I'm going to share a little bit of our experiences that I have in Toronto. As we all know that these days VR surgery involves injection of gas for macular hole, for retinal detachment surgery. And the problem with the intraocular gas injections is that we advise our patients with the gas that they cannot travel in the airplane. And the reason why is that we saw that in the airplane, when we have a bag of chips, they will inflate. And with that will cause increased intraocular pressure in the eye, and that's the reason why we advised against traveling. And it is not a trivial issue. In fact, there was a news clipping that the Greek Prime Minister, he canceled his EU summit meeting after a retinal detachment repair surgery. He has gas put in by his retinal surgeons, and he was told he cannot go. And it was an important summit that he has to be there so that he get money for his country. But he couldn't go because of the intraocular gas. So I just want to maybe take a few moments to explain to you what happened to the gas in a high altitude. Okay, so this picture is what happened to the gas bubble at sea level, but at a higher level where the atmospheric pressure is lower, the gas will expand, and that's what's happened to the bag of potato chips in the airplane. But the eye actually accommodate for the changes. The sclera was stretched, there was increased aqueous outflow, and then you get a new balance occurred. So you do have an increased rise of pressure, but then the pressure will stabilize. So in fact, there was a study has been done putting about 0.5 cc of gas inside the eye of a retractomized monkey and simulating a like airplane ride with a rise of the intraocular pressure slowly to about 8,000 feet. The 8,000 feet is important because most of the airplane are pressurized at that. And with a slow increase, the pressure only go up to about 34 millimeter mercury. But in a rapid ascent, in the less than a few minutes, then the pressure can go up to 49 millimeter mercury. And the reason why it went up so quickly is that the eye could not accommodate for that sudden changes in the expansion of the gas. So is it safe at all to travel in that case? It sounds like it's probably quite dangerous. In fact, Kokami and Ng in 1994 reported a case, a patient who was traveling at low altitude, about 3,000 feet, that is in Hawaii, and the gas was the patient had retinal surgery done, and he has about 60% gas. And he was able to tolerate the procedure with no pain and no loss of vision, but the intraocular pressure was high. It was 40 millimeter mercury. There are other study that was done, but using animal model. Diker in 1986 using a monkey model, they using a simulated flight situation in a hyperbaric chamber, and they found that the intraocular pressure rises is linear related to the percentage of the gas bubble inside the eye. For 6% gas bubble, it rises to 30 millimeter mercury. A 13% gas bubble will rise to 34 millimeter mercury. Similarly, Linkoff, a couple years later, also showed a kind of similar finding that in a non-retractomized live rabbit eye, when they create a hyperbaric chamber simulations to air flight situations, where they found that a smaller gas bubble, they inject different sized gas bubble and look at the changes in the intraocular pressure, they found that a 10% gas bubble only about 6 millimeter mercury increase in the intraocular pressure. So it gives us an idea that a small gas bubble may be able to tolerate in the air flight situation similar to the one that was noted in the Hawaii by Kokami. So we, in 2001, did a study looking at the changes in intraocular pressure in the patient with a gas bubble in their eye in a simulated air flight situations. We were very lucky because we were able to get cooperation from the Defense Department from Canada. They have this hyperbaric chamber. So this is a setup like in a room larger, like all the machines larger than this place. And this is the console where the a flight surgeon and technician control the hyperbaric chamber. And there's a window right next to it that they can actually look into the chamber, and this is the chamber. And they use this to train pilots and astronauts. They can change the room in atmospheric pressure from any number you want. And that also means that you can bring back to sea level at any time that you want. So we were very lucky to get cooperations with them because they use this to train NASA astronauts for putting them to very difficult and different scenarios. So this is the 10 patients that we look at, and you can see that they all have surgery and have different gas, and they have their baseline intraocular pressure ranging from 10 to about 22 millimeter mercury. And so this is the graph. So you can see everybody, the intraocular pressure rises. The gray line, that's the control. And then after at the ascent part of because just like the airplane, they rise, and then they cruise, and then they land. So this is what we're trying to create. So we see that they rise very quickly through the ascent part of the flight, and then they kind of level out in the cruising. And when they descend, the bubble actually gets smaller, and the pressure actually drops. The intraocular pressure drops. So we found that the peak intraocular pressure in those patients can range between 13 to as high as about 33 in a 10% or 15% gas bubble. But in the patient with a larger gas bubble, they are a little higher. And when they are in the descent part of the pathway, the pressure is lower. So we saw that. So yes, it is true. The gas expand 109% above baseline when during the ascent part of the air flight. And that was because the compensatory mechanism, such as the choroidal compression, the stretching of the sclera, and the increased outflow cannot match. But with time, the IOP actually leveled out, and it dropped down from 100% rises to only 30% above the baseline. And then when in the descent part, when the plane starts to land, the pressure actually dropped about a third of the baseline. Then we ask the questions. So we know gas bubble does change it. But what happens if the patient have a scleral buckle? Does it change anything? Scleral buckle, although it's done less, but it's still done in our surgery. And interestingly, when I look in the literature, the lab study has shown that, yes, the presence of the scleral buckle actually changes the way the eye responds to the increase in intraocular pressure. The scleral buckle is much more elastic than the sclera. In fact, if an eye that have an encircling band, it will able to accommodate 4 times the volume with the same changes in the IOP. So yes, it is possible. In fact, if you take out the band, that kind of that expansion accommodation is reversed, so back to normal. If you make the scleral buckle higher, they will actually able to accommodate in larger volume. So yes, so the present scleral buckle can allow the eye to accommodate for a larger volume, it seems. But is this the elasticity of the buckle, or is it the scleral buckle itself? So around the same year, another study was done that they used a steel ring. And with the steel ring, you also get the same kind of accommodations. There is the eye can able to accommodate a larger volume compared to those eye that doesn't have a ring around it. And the reason is not because the ring is more elastic, it's just it changes the shape from a sphere to a oval shaped. So the forces can distribute it differently, and they were able to accommodate more pressure rises. So we want to repeat the same study, and I already told you using the hyperbaric chamber. And this time, we have patients who has scleral buckle and vitrectomy. And we have 12 patients, 6 with scleral buckle and 6 without scleral buckle, and has a gas bubble that is about 10%. And we pressurize the cabinet to 8,000 square feet. The question people will ask, why 8,000 square feet? Why not, lower or higher? And important to know that at 35,000 feet, you lost consciousness. and that's where the plane travel. So that's why for inside the cabinet, they have to pressurize 8,000 feet so that you still awake in the traveling. And you can see that the pressure differential between outside the cabinet and inside the cabinet is well within the capacity of the plane to accommodate. For the plane to able to accommodate higher pressure differences, it has to build more stronger body, so you become more weight. And if you want to pressurize the cabinet to sea level, you also have to consume more fuel. So for economic reason as well as for logistical reason, that's why the cabinet is always pressure at 8,000 feet for commercial flight. So this is the typical way that the flight is. They rise about 300 feet per minute, and that's the kind of ascending part. And then they cruise for about 30 minutes, and then they descend. And so this is exactly what we do. And the pressure was measured every 5 minutes. And then we found that the pressure rise differently between those with buckle and those without buckle. And we find that there is a significant rise from 40 millimeter to 29 millimeter mercury, 8,000 feet. There's a 100% increases. So this is similar to what we see in the first time. But a couple of the patient who is in the non-scleral buckle patient has the IOP more than 40 millimeter mercury. So we have to abort that study. Then when we look at the graph of those with buckle and without buckle, we can see that, without this, the red line is without buckle, the blue is the with buckle. You can see that those with the buckle are consistently have a lower intraocular pressure during the entire flight simulation, the pathway. And those who has scleral buckle has lower intraocular pressure at its peak, about 30 millimeter mercury compared to 39 those without the buckle. And the increase of IOP in those in the scleral buckle eye has 7 millimeter compared to 23 millimeter, almost 3 times less increases. And and you can see that there's about twice the percentage of rises in the non-buckle eye. So in conclusions, so eye with intraocular gas do show increased intraocular pressure in the flight situations, in the high altitude and the low atmospheric pressure, and the rise is about 100%. Those who has scleral buckle in a small gas volume were able to tolerate the rises much better with a less increase in the pressure. So it may be possible in some patient that it is able to travel, especially if we start off with a small gas bubble and if they actually have a scleral buckle put on in the eye for their surgery. Thank you for your attention.
Thank you, Dr. Lam. I just have one question.
Yeah.
I mean, after your talk, I mean, would you advise a patient, no matter what type of gas he has been injected or what volume, would you be able to advise him to travel by air safely? Or because every patient will respond very unpredictably, you know. There could be one patient who might have much more expansion than the other. So, I mean, considering that fact, do you think it's safe to write to a patient that he can travel safely? Or would you be...
No, that's a very good question, because that's been the question that we have asked ever since too. We have seen the gas expand. That is a physical phenomenon, so we don't doubt that at all. And it will expand about 100% time. So for a 10% bubble, it becomes a 20% bubble, basically. How the eye accommodates to do the changes is variable. And we've seen that there is variation, but the variations are within 5 millimeter of mercury about, for when we look at the 20 patients that we see between the two groups. So if you have patients who have the pre-flight intraocular pressure that is less than 10 or around 10, you know that you have enough safety margins to work with. So we actually have done that with patients, that we actually deliberately lower their intraocular pressure with medications, and then also give them extra medications to go on the body if they feel that they get these sensations, the eye is uncomfortable. Nowadays, it is actually possible to do that with the eye care. The eye care, you can actually do self-IOP measurement. So you actually could potentially do that. Of course, it will be simpler to say not to travel, but there are certain circumstances that it may be necessary. And so what our study has provided is that you have an opportunity to look at there are certain specific situation that you might consider allow the patient to travel if you take the precaution. The bubble has to be less than 10% or 10%. Cannot be more, because I think it will create much more difficulty because the volume expansion that you have. So you have to have two criteria, small volume and low baseline intraocular pressure to start with. And it will help if you have a buccal too.
But there's another question that
Yeah.
if that sudden rise of intraocular pressure does happen, he's on a long flight, a transatlantic flight, or he's on a long flight, and such a rise of intraocular pressure happens, it may not immediately cause any problems, but there could be long-term effects of that acute rise of intraocular pressure which may have happened during this flight. You see, maybe not an immediate glaucomatous optic neuropathy, but at some point of time, that disc could decompensate because of some kind of vascular occlusions that might be happening. So I mean,
correct.
Yes,
And I think the very second slide I show is that the commercial airplane rises, they are not rising suddenly. It's different than the fighter pilots, where they have to ascend very high altitude very quickly. And majority of the commercial flight ascend about 300 feet per minute. So it's not as if they are going to shoot up. And so I think you can see the ascent part of the, in a gradual ascent, it rises to 34 millimeter mercury. But in a rapid ascent, in a few minutes, you can go up to 49 millimeter mercury. So in that consideration, in a normal commercial flight situation, you wouldn't get into the trouble of a sudden increase in intraocular pressure to that extent. So that is reassuring. And I won't advise a fighter pilot to do this, of course. Thank you.
Thank you. Any other questions? Yeah. Thanks a lot, Doctor. Start. So we'll start this session on pediatric glaucoma, and I would just like to introduce this topic primarily because this is glaucoma in young people, and the fact that our population is primarily young, it's rising, and we have large number of people at a young age, and most common causes that we are going to discuss is trauma, congenital anomalies, steroid-induced glaucoma. Importantly is that this is a very important socially productive age group with huge economic ramifications for as far as blindness is concerned. The fact that they have to use long-term medications and that there could be issues with compliance and quality of life. So we start with congenital glaucomas, where Dr. Sirisha from LV Prasad is going, where she has got a tremendous amount of work on congenital glaucomas, and she's going to show her surgical expertise with managing congenital glaucomas.
Good afternoon, everyone. So I think childhood glaucoma is one of the most difficult subspecialties of glaucoma, and whoever is present in the room, directly or indirectly, we are involved with treating children with childhood glaucomas. We understand that it is not just challenging to diagnose, but to be able to evaluate them as well as to treat, and the challenges of trying to rehabilitate them visually as well as have a lifelong follow-up, where we know that as long as they live, there's going to be some problem or the other. So as the longer they live, there are going to be problems with the surgeries. That means they're going to be long-term failures. So they will require additional therapies as we go by. Another big challenge is that there's a huge variation in the presentation as well as the severity of the phenotypes that we see. And as a part of the International Pilot Survey of Childhood Glaucoma, to look at the profile of childhood glaucoma, when we had looked at prospectively our own patients, for about 15 months, we had 277 children who visited our institute. Majority of the glaucomas were primary congenital glaucoma. Second to that was secondary acquired and secondary developmental glaucoma. Close to 75 to 80% of them were primary or secondary developmental glaucomas. So we know that there is a structural abnormality in the angle in these children when they are born. Either there is a goniodysgenesis or a trabecular dysgenesis or a iridodysgenesis, or a combination of all these factors. And as far as the primary congenital glaucoma is concerned, there is an isolated trabecular dysgenesis. There is no other structural abnormality, at least that is visible for us. And we know that there's a very, very severe phenotypic presentation of congenital glaucoma, primary congenital glaucoma in India. These are the kind of eyes that we see. That is because of, I think, a couple of reasons that we have. We have something called a founder effect. That means especially in the south of India, the consanguineous marriages, marrying among the families are quite high. So there's a lot of inbreeding that happens in India as well as in the Middle Eastern countries, where the severity of the glaucoma goes on increasing as time goes by. So we see them as much more common, or 3 times more common as is seen in the Western population, and the severity of the disease is also quite high. We know that the treatment option for primary congenital glaucoma is definitive, is surgical. Of course, medical treatment will help if the baby is waiting for and fitness for anesthesia, or possibly temporarily to clear a cornea a little bit for whatever reasons if we have to wait. But otherwise, essentially it is surgery. The choices of surgery that we have range from goniotomy, trabeculotomy, combined trabeculotomy and trabeculectomy and trabeculectomy. Like we said, the problem here is abnormal angle development or the trabecular meshwork development. So the choice of surgery, apart from so many other factors that are there, 3 important factors are presence of clarity in the cornea. So corneal clarity is very important, corneal diameter. That apart, I think surgeon's experience plays a great role. Goniotomy is one such technique where I think this is one of the first techniques that was used to treat children with congenital glaucoma. Earlier than this, any child with a congenital glaucoma was in fact considered as somebody who was not treatable, and most of these children or all of these children inevitably would go blind because we didn't know how to treat them. And with goniotomy, there was some kind of a help, and it definitely helped to bring down the pressures in these children, and a lot of them started having clearer corneas. In this technique, you require a direct gonio lens to be able to visualize the angle structures. It's quite quick to do. It is pretty atraumatic. It depends upon how we do it, and of course there is conjunctival sparing. So this is one of the video that I borrowed from Dr. Sharon Friedman when I was visiting her, because goniotomy is not a technique that at least we are used to, and we have not seen our mentors do it because none of our corneas are as clear as what they see in the West. So a direct gonio lens is used. Helon was placed on the cornea. If you notice this lens, the way it is placed on the cornea, it doesn't sit on the cornea, because the more it indents, you start seeing folds, and it's very difficult for you to see the angle structure. So a thick viscoelastic is placed, and the lens is just held on the cornea to be able to visualize the angle. And you use a little sturdy and a long needle, not a bent needle but a straight needle. It depends upon what is comfortable for you. Basically visualize the angle structures, just go above the trabecular meshwork and try to literally scratch that area. You see the iris fall back, as well as that helps to open up the Schlemm's canal. So in fact, after watching her surgeries as well as her videos, there are a couple of indications that we have come across where I think this is very useful even in our own eyes. And then I started doing that, and for the past 2 years we have not too many, but maybe about 20-25 eyes that we have operated, both primary as well as secondary congenital glaucoma. I'll come to that later. So basically we have to use a tilt in the microscope, use a direct gonio lens. A lot of surgical gonio lenses are available today because of the angle surgeries that people are doing. And it is extremely useful in the sense, like especially in some types of glaucomas where you know that the cornea is clear and you don't want to touch the conjunctiva. This is pretty useful. And the earlier you do the surgery, the better the success rates are. And of course, if the corneal clarity is not good, or if the corneal enlargement is too much, more than 14 millimeters of diameter, the Schlemm's canal obliteration happens. So identifying as well as to be able to do the procedure, although we would be able to successfully do it, the success rates are not very good. Trabeculotomy is another technique where the similar kind of thing, the trabecular meshwork is kind of opened up, and you create a communication between the anterior chamber and the Schlemm's canal, but this is done ab externo or ab interno. Ab interno is you go inside the eye and try to open up, whereas the ab externo technique is what we routinely follow. This can be done with the help of a trabeculotome, Ham's trabeculotome, or using a Prolene suture or an illuminated microcatheter. This can be performed in all types of severities of glaucoma where even the corneal clarity is not good, which is what typically we see. It doesn't require any special lens. But yes, it does require expertise for you to be able to locate the Schlemm's canal. It takes a little longer time, and of course conjunctival opening is done. So whether we do a superior trabeculotomy or you do a slightly supraonasal or supratemporal trabeculotomy because you don't form a large bleb, so that you spare the superior conjunctiva is something that we debate, and it depends upon what you are comfortable with. So which technique is better? I don't think one is superior over the other, but when you consider the types of glaucomas, the severities of glaucomas, goniotomy is able to bring down intraocular pressure by about 64 to 77% of the eyes if you consider even the advanced, the more severe glaucomas, while trabeculotomy has a better success rates compared to goniotomy, but head-on-head comparison between these two techniques are not available. Combined trabeculotomy and trabeculectomy is something that we routinely perform, and the technique goes like superior, like I said, superior or supranasal or supratemporal, whatever one is comfortable with, but routinely what we perform is the limbal-based conjunctival approach. So it's exactly like a trabeculectomy. Once you make a superficial scleral flap, we try and identify the Schlemm's canal. A couple of things that helps us, in fact, when we teach our fellows how to identify the Schlemm's canal, is that when you're trying to dissect, you realize there are two important things. One is you see small perforating vessels that are arising in the area where you will be able to identify the Schlemm's canal. That is where the collected channels possibly are trying to connect. That's number one. Number two, you see a very tiny dip. There's a small depression that is present at the area of the canal. So while we are dissecting, these are two things that we try and look at, and they will definitely help us to identify the Schlemm's canal, locate the Schlemm's canal in a proper way. So once we locate the Schlemm's canal, we do it around 100 to 120 degrees. We try to open up, see that posterior glistening membrane as well as a dip or a depression that you see in the center. This is the Ham's trabeculotome that is used. So it has a guide which helps you to understand where exactly the trabeculotome is passing, because most often the false passages in these soft eyes are very, very common. So you can do it to about 100 to 120 degrees, and followed by, you continue this with the, I'll just forward this, continue this with the trabeculectomy part as well. We have published our results where Dr. Mandal's alone, the data that showed about 85% success rate at 1 year and dropped down to 57% by 6 years. So combined trabeculotomy and trabeculectomy is definitely useful, and in our kind of glaucomas, I think that is one technique which is very useful. So what are the modifications and what are different combinations that we use? So this is a child with primary congenital glaucoma who had grade 4 corneal edema. Post primary trabeculotomy and trabeculectomy, the cornea cleared to almost about grade 2, but not more than that. You see multiple Hab striae that are present. This eye actually has had a tube. You can see the tube there. The cornea is significantly cleared. This eye actually was much worse, where it had much more corneal edema and the pressures were too high. So we didn't consider doing any other procedure, so went ahead and did a tube in that eye. For this eye, the second eye, where the pressures were not too high, the cornea was not very clear, but yes, we could manage to see something. So we did a goniotomy in this eye. So sometimes PCG eyes, after we have done the primary procedure, if the cornea clears a little bit, to go and do a goniotomy in the inferior quadrant is a possibility. Aphakic glaucoma especially, we are doing something called a combined goniotomy and a trabeculotomy. That means you do a goniotomy in the inferior quadrant and do the trabeculotomy in the superior quadrant. So this was a child who was aphakic 0.3 CD ratio, but pressures of 40, just not coming down, and angles are completely open. So if you have a procedure where you will not touch too much of, you will not induce too much of hypotony and complications like that. So I think we would definitely be happier and safer to do a procedure like that. Other modifications that are available are 360-degree trabeculotomy using illuminated microcatheter. This, I think, is an extremely good procedure the only problem is that you treat 360-degree angle, so obviously the success rate we think should be better, but at least the recent results have shown that they are not superior to the conventional trabeculotomies that we do. But the problem is that it's very expensive. The illuminated microcatheter is not reusable and it is very expensive, so the cost is an important factor. Maybe if we get something which is disposable and is less expensive, it would be very useful for us. Other technique which people do, especially in the Middle East, recently we had a professor who visited us, and he was saying that he was very skeptical about the use of non-penetrating deep sclerectomies in children with primary congenital glaucoma, but he's found very good results in patients with in the Middle Eastern eyes. So viscocanalostomy is one more procedure that people do. Whether it is goniotomy, trabeculotomy, or a combined procedure or 360-degree trabeculotomy, whatever we do, I think what is most important is that we need to understand that we need to be comfortable in whichever procedure we are doing, and all these eyes at some point in time will require additional medication, and sometimes they require additional procedures as well. So surgery, like I said, is just a beginning, but I think once we finish the surgery and you achieved whatever you need to achieve in terms of intraocular pressure control, periodic assessment to see how things are, as well as to understand these eyes. Most of them are myopic eyes, astigmatism because of the corneal HAB striae that these children have. Amblyopia management is extremely important, and to rehabilitate them and make sure that we help them throughout their life with the rehabilitation as well as the refractive correction. Thank you.
Yeah. Any questions regarding congenital glaucoma management? What is your experience, Risha, with the goniotomy that you have done? I mean, have you those 20 cases of goniotomy that you did? I mean, do you think it can be used more often in our children?
I think it can be used. It definitely has a role to play. So in the beginning, we did have difficulty. So one of the problems, I'll tell you what problems we had was, so if it is written as a 26 gauge needle that we need to use to go and do a goniotomy, the length of the 26 gauge needle doesn't even reach midway through. So simple things like that we had to figure out, and you can't use much thinner needle. You need to use a thicker one. But these children, the corneas are very, very fragile, and they're very soft. So you definitely need to take a suture bite there. Yeah. Sometimes you start losing the chamber if you use a very large needle. Yeah. So starting from that, what we figured out is what works for me is 24 gauge needle, and temporally sit temporally and try and use an assistant to hold the conjunctiva with a toothed forceps, and using a 15-degree tilt and a surgical gonio lens. About 100 to 120 degree is something that we can treat. But once you go in, you need to complete it. Otherwise, the minute you try and decompress and a little bit of hypotonia is there, it starts bleeding from all over the place. And then after that, it's a mess. You can't go ahead and do it. So teaching is very, very difficult. In fact, we are thinking of having with the World Pediatric Ophthalmology Congress during that time, a workshop where I think we need to be doing it more often in our eyes, especially in the secondary glaucomas like aphakic glaucomas, post-congenital cataract surgery, aniridias, and the spirophakia is one group where they undergo lensectomy, post-lensectomy, open angles, where I think about 4 or 5 children I have operated. I'm quite happy with the results. Yeah. So they're off medications, very, very low diffuse blood. That's I've done a combined trabeculotomy with a goniotomy. Aphakic eyes, obviously, nothing better than that. Yeah. I haven't analyzed it. This is not a uniform cohort because, like I said, the indications are varied. Couple of primary surgeries were already done. Some of them were done as the primary surgery. So I think maybe as we go by, we'll have better results. But yes, it does work. And even if it means you need to give one more medication, I think I'm okay with it.
Sure, absolutely. Another situation is when the eye is very large, 14 millimeters, 15 millimeters eyes. Do you think that most of these surgical options, including trabeculotomy and trabeculectomy, work? I mean, would you give a chance for an AGV as a first shot in an eye which is very large?
No.
No?
No. Okay. Yes, identifying the Schlemm's canal is very difficult. Sometimes we may not be able to even identify. Yeah. Even if you identify, you can't cannulate it properly. But I would still go by a non-implant procedure.
Sure.
If the corneal edema is, let's say, grade 2 or less, anything beyond grade 3 or more, I think I would prefer to do a combined procedure. If it is a very mild, in fact, I've done one eye, if usually they present asymmetrically, one eye is grade 4, grade 5, and the other eye is just grade 2, then I will do a trabeculotomy on one side and a combined on the other side. That works well. If it is a very young child, less than 2 years, less than 3 years, then no glued IOL. Otherwise, the child who is little older, they're doing lensectomy with glued IOL. In fact, the results have been really, really good. I don't know how they behave 10 years from now, 20 years from now, but if these children present with very, very high myopic refractive error like 25, 26, you can't even rehabilitate them. So they do lensectomy for them. So invariably, by the time they come to you, lensectomy is done with anterior vitrectomy done, but pressures are very high. So
I want to share something like for last 8 years, I'm doing a standard PCRL, and I've got 4 eyes, 7 years experience. It doesn't go anywhere. The lenses are in place, and the eyes behave extremely well.
no, this is that I understand. So it's a wide spectrum.
These are big children, not small ones. Like
Yeah.
15 years, 14 years, 10 years.
If someone with microspherophakia, we know that as the time goes by, they present more with problems and complications. If somebody is so young, who's just 1 year old or 2 years old, presenting with such kind of a refractive error and high IOP, that means there is primarily something wrong even with their drainage angle. So it's not just related to microspherophakia, but I think it's also related to the drainage system where the entire thing is not okay. So they are all, I'm talking about open angles. They are not angle closures, there are no synechia, nothing. So these, I think it's a huge spectrum, so we can't generalize it. But yes, older children and older adults, yeah, that's an option.
Reported, actually, I'm bad at writing, but it's systemically reported that it's not always that lensectomy and
Yeah.
lensectomy.
Yeah.
There are lots of children who come actually with spherophakia and white cornea and huge eye because they've been not treated.
Treated, yes.
If you are doing a trabeculotomy, which do you choose the inferior quadrants or lateral quadrants because keep the conjunctiva versus the superior?
It's supranasal or supratemporal. I don't go completely temporal. No, I'm not somebody who's comfortable doing that.
Do you open the whole thing like this or
Smaller opening. It's a very small opening because at least about 4-5 millimeters we definitely need to open up the conjunctiva, but it's so posterior. That is because you need to have an access to the anterior part of that is the peripheral part of the cornea. So you will require about 4 to 5 millimeters. Not bang on 12 o'clock, but slightly supranasal or supratemporal. Big eyes is combined trabeculotomy and trabeculectomy. If we are able to, most often we are able to identify. So 90% of the time you can identify the Schlemm's canal, but if you can't, then we proceed with the trabeculectomy. So I have done modified, like you can't identify the Schlemm's canal, but once you remove the deep block and you see that there is floor of the Schlemm's canal that is there underneath. So without doing an iridectomy, going through the floor of the Schlemm's canal to be able to do a trabeculotomy is also something that we've done in these large eyes where it's very difficult. It's so thin that by the time you give a single incision, I think you've already entered inside. So we keep on modifying things because whatever we do, I think we need to do the best for this intensive anesthesia because these large eyes are the ones that are more prone to suprachoroidal hemorrhages and all these problems. Although they don't record a very high intraocular pressure, but these eyes are all stretched. So any sudden hypotony can cause a problem. No. 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 No conjunctival incision because I've seen more problems. Yeah. Sorry, not conjunctival. The corneal incisions. No corneal incisions for these children. Yeah. In fact, if I'm doing a combined surgery with any of the, let's say a lens aspiration with this procedure, something like that, to just close the side port, I take as much time as that I've done the surgery because these children's eyes are so difficult to close and then they keep leaking from all over the place. Yeah. So corneal incision or the corneal entry, that's why even for goniotomy, like I said, the smaller the needle, I would have been very happy. But the problem is that I think BD Visitech has 26 gauge needle with a 1.5 inch. What we have is only ½ inch. We tried to get them, but it was not available with us. So we are using 24 gauge needle. But then I think we should be able to get it. Another, the advice one of the anesthetists was giving was a lumbar puncture needle. They're quite sturdy. They're quite long. That's something that we can use because they don't, otherwise if it is too thin, like 29-30 gauge, they're very flimsy. They don't go and incise the tissue properly. Yeah.
there is sometimes an anaretic eye,
Yeah, it's not about the shallowness. My worry is about the suture there, and I need to take them up under EUA another time to be. One is putting it, number two is to go and remove it, because these edematous corneas, once the edema clears, the suture becomes loose. Suture becomes loose in no time, in about a week or two, so we need to go back and remove them. So multiple reasons, because many of them are even lost to follow-up. They come back after 1 month, 2 months, or you don't even see them. So it's very difficult to be able to. I've seen one child who developed an infiltrate in that area. So I think post that, anything that happens to you, it sticks on to you, right? You definitely don't want it. Yeah. Yeah.
But no, but the IOP might go high. I mean, I think but you don't do EUAs after 3 days or 4 days in these kids, you see.
Side port, you're saying? No. Small children, I am very, very skeptical about it. I don't think I would be comfortable leaving it. So it's working well for us without a paracentesis, and if things are fine. In fact, we put the cycloplegic immediately after we close the scleral flap. So by the time you finish your conjunctival suturing, the anterior chamber is already formed. By the time you finish the other eye surgery, we do simultaneous bilateral. By the time we finish the other eye surgery, the AC is quite deep there. So when we don't need it, why another intervention? That's the only thing. If nothing is wrong. I mean, if you're used to doing it, and then if you can try and titrate your bleb and things like that, it's fine. But it's worked well for us, so we don't do it.
1 month ago, a suture removal from side port, a patient developed endometriosis.
That's what I've seen. I've seen it develop in one of the pediatric cases.
Next.
Sure.
Yes, thanks a lot,
Okay,
Sirisha.
thank you.
We have Dr. Brigadier Major General Patyal going to tell us something about children with trauma. So another very important cause of pediatric glaucoma is kids coming with trauma. And once a child has trauma, you have to follow up that child for lifelong, because not just that particular time, but he can develop glaucoma later on. So we have pediatric glaucoma following trauma.
पहला वाला Yeah. Thank you, Dr. Viney. And I'm going straight to my topic because I realize that time is really running short. And so we had this 10-year-old male boy, a male, who was injured by a cricket ball. All of us know that children get injured because they keep on playing. And in the left eye, on August of 2010, he was found in another hospital where it happened. He was found to have raised intraocular pressure, and he had also found to have angle recession in the left eye in 2013. And in 2013, as you can see, his vision was pretty good, and his left eye pressure was high. His pachy's were a little on the thinner side. He had open angles in the right eye. In the left eye, he had angle recession, and he was being treated with 4 anti-glaucoma drugs, and the pressures were 30. So he underwent trabeculectomy in our hospital in 2013. This unfortunately failed after 1 year, and he underwent an Emmett glaucoma valve implantation in January 2014. What I'm trying to show you is that this is the normal way the children are seen with trauma, and especially with angle recession. And they have to be followed up lifelong. In 2016, his vision was fortunately 6/6 in each eye. Pressures were normal. You can see the disc, everything was normal. But you must be wondering why we did not do the fields. And therefore, I come to the definition of traumatic pediatric glaucoma. That is when you have a post-traumatic intraocular pressure of any child who has received an injury being more than 21 millimeter of mercury. This may be acute, it may be chronic, and it occurs in a child who is lesser than 12 years of age, who's had a history of either blunt or penetrating injury. And we must not forget this penetrating injury can also result in a lot of glaucoma, and with or without the establishment of glaucomatous optic neuropathy on visual field testing. So therefore, the definition of traumatic glaucoma is slightly different from a normal understanding of what glaucoma is actually. It's got a huge prevalence, and unfortunately in India we don't have figures. But in the US, they say eye trauma is the leading cause of non-congenital monoocular blindness in persons less than 20 years of age. If we look at the figures, 1,60,000 to 2,80,000 of children below 15 years of age every year sustain ocular trauma, which is serious enough that they've got to be hospitalized. But we are forgetting that there's a large number of children who are not hospitalized, and they amount to approximately 3.3 to 5.7 million annually. We know that toys children play with, and obviously between the 2 and 4 year olds and injury from falls, when they're learning to walk, that's the time when this type of injury may be ignored. But we cannot and should not ignore this, and the children must be seen thoroughly. From Northwest India, we have only one report of 45% of children being affected by sport-related injuries due to gilli danda. Bows and arrows, when the initial, if you remember Ramayana and Mahabharata, when it come up, the epic dramas in the television, lots of children were affected by this particular type of mode of injury. Unfortunately, because children are not able to speak, and therefore they cannot tell you, and they've got a very immature visual system, they manifest by the time you've come to know that the child has got already landed up with problems because of glaucoma. He comes up with strabismus, and that tells the entire story, or he has nystagmus because of blunt trauma. Of all the type of manifestations, you find that hyphema, that's 32% of all traumas, is the most common finding following ocular trauma in children. So why is it that we are trying to talk about children, ocular trauma in children? We must realize that they are not small adults. We have to do early diagnosis and give them appropriate treatment. Whatever procedure we plan for these children should not interfere or compromise with the potential success of subsequent procedures. Mind you, these children may require procedures later on. Therefore, whatever surgical interventions we do, they may have again complications, and they may come up over an extended period of time. So these children, even when you have done a procedure, you have to follow them up. Therefore, once you have done the treatment, we must remember that they might have strabismus, refractive amblyopia, media opacities, they may develop cataract, and therefore they again have to be treated. So your patient who landed up with a blunt injury, landed up with a glaucoma, now has to be given treatment for his amblyopia. He may require penetrating keratoplasty. And along with that, so he may also have an RD. So we have to treat all that. And most important, what Dr. Shirish has already said, we cannot examine these small children, especially who come to us, without an EUA. And remind you, these children have to keep on doing repeated EUAs. And also children who are coming in their late teens, they also might land up with progressive myopia, and therefore we must think of glaucoma in these patients. What are the things which predict the development of chronic glaucoma after injury? Are increased pigmentation as reported by Sehota et al., high baseline intraocular pressure, absence of any kind of cyclodialysis cleft, hyphema, angle recession greater than 180 degrees, or lens injury. If your baseline visual acuity was below 20/200, if there was anterior chamber inflammation, uveitis is a massive cause, penetrating ocular trauma, vitreous hemorrhage, or if you have, as has been reported from the African subcontinent, presence of an intraocular foreign body might also cause you concern. And you can have traumatic glaucoma because of various reasons. The lens is a huge culprit. It may be subluxated, dislocated. You might have lens particle glaucoma, phacolytic glaucoma. As I said, inflammation of the eye, uveitis may also cause it. The trabecular dysfunction, the trabeculitis which occurs because of blunt trauma, that itself might incite your glaucoma. Or you might, of course, have hyphema, shallow anterior chamber. Now the posterior chamber also doesn't get left behind. And it causes this immense amount of pressure from behind, resulting in, again, glaucoma and, of course, angle recession. You might have an acute rise of intraocular pressure after trauma. And that's, again, because of occlusion of the trabecular meshwork by either the blood clot, by inflammatory cells, red blood cells. You might have a pupillary block. And just remember that a large glaucoma, a large hyphema, greater chances of glaucoma. But when you have a patient who has got sickle cell disease, if he's got a small hyphema, that patient might land up with a huge amount of intraocular pressure rise. So you might have traumatic hyphema in children because of birth or prenatal trauma, because of trauma due to blunt objects, scleral rupture, iridodialysis, due to tear of the anterior face of the ciliary body. Child abuse must not be forgotten. So when a child comes to you with this, please keep that at the back of your mind. Of course, sports-related injuries are known cause. And we know the traumatic hyphema, how it is caused. So as we know, the traumatic hyphema can be in a small amount, gradation of hyphema is there, but it can cause immense amount of blood staining. And what we must not forget is that once you've got a hyphema, you might have a rebleed. So wait and hang on and have a look at the child for at least 3 to 5 days. And this rebleed may result in increase in hyphema size, it might have increased intraocular pressure, corneal blood staining, optic atrophy, and of course SPAS. And once the blood staining takes place, you have fine yellow-colored granules. That's how you're supposed to be looking for it in the posterior stroma. It extends very gradually into the Bowman's membrane and even the epithelium. But clearing takes place again from peripherally to centrally. Very important facts about children. If you have a child who has had a blunt trauma, somnolence, the child feels more sleepy than normal. This may be a presenting sign in children with hyphema. Any intraocular pressure over 21 millimeter of mercury, please treat it. All individuals with a history of significant ocular trauma they require lifelong surveillance for the onset and progression of ocular hypertension and or glaucoma. Now you have angle recession glaucoma. You find that the angle recession might occur in 20 to 94% of people. But fortunately for us, only 5 to 20% might develop glaucoma. And if you realize that from United States, unfortunately in our country we don't have these kind of registries, this angle recession glaucoma accounts for 2.67 of all penetrating ocular injuries result in traumatic glaucoma. So you can have non-penetrating ocular trauma which results in angle recession. You can visualize it by conioscopy or UBM. Eyes with 180 to 360 degrees of recession, you have a greater chance of glaucoma, and patients with angle recession glaucoma develop glaucoma more in their fellow eye than by chance itself. So this is one thing that we must remember. And cause of obstruction is obviously because there is either a membrane-like thing which grows on the angle or because of the scarring that has taken place. So don't look at the recession. The recession merely tells you that there has been previous trauma. And penetrating ocular trauma itself also causes a lot of glaucoma because of various reasons: blockage of the angle, inflammation, angle closure, or long-standing vitreous hemorrhage. Now, degenerated RBCs can result in a large amount of traumatic glaucoma. Fortunately for us, that in children, in a series of 200 cases, they did not find any case of co-cell glaucoma. As we know, co-cell glaucoma occurs practically after 3 weeks of the initial injury, when the cells get degenerated and they become spherical, unable to pass out of the trabeculum, and therefore they result in glaucoma. So how do we control this glaucoma? We have medical means, topical beta blockers, CIAs. Now the systemic CIAs also can be tolerated by children. Dose I've given. Try to avoid PGAs, but there is no consensus on the role of PGAs being used in children. But what you must avoid? Avoid alpha-2 agonists for whatever reasons I have given. Avoid the miotics and cholinergics for once again reasons which I have given. And what must not be forgotten is that in sickle cell disease or trait with traumatic glaucoma, please avoid systemic and topical CIAs, alpha-2 agonists, and of course mannitol. And you can treat them with cycloplegics, have to treat them in fact with long-acting cycloplegics are much better. In cases of children, use steroids. And in cases of intraocular bleed, please avoid aspirin, NSAIDs, coagulation therapy. And for surgery, you can do as per the World Glaucoma Association. They say for total hyphema, partial hyphema with IOP greater than 30, or with corneal blood staining, one must go in for either a washout or for a surgery. There's a video here, but I'm not going into it because I've exceeded my time. And thank you all for your patient hearing. Any questions, please let me know.
Thank you, Dr. Sagarika. We'll have Dr. Harsh presenting the next talk, which is on something that is rare in children but can happen. This is about neovascular glaucoma happening in children. But before that, okay, I'll take up the next talk. Any questions regarding trauma in children, trauma and traumatic glaucoma? Yeah, generally they say less than 10 years, but there is no particular line. I mean, there is nothing in literature to say 6 years, 7 years, or yeah. Okay.
that there is no cutoff age at all, where in some books have said even 6 years, 10 years. But what I want to also point out that, alpha agonists must also be very careful when you give it to adults, because they complain of increased fatigability, and you find actually it's an effect of the alpha agonist.
So we'll go on to the next important talk, which is about steroid-induced glaucoma in children. And this is a major problem in our country. The most common cause of steroid-induced glaucoma is vernal keratoconjunctivitis, for which steroids are generally prescribed. And if steroid-induced glaucoma happens in a child, I think it's iatrogenic, and it's a big blunder and should not happen because of the economic ramifications of a blind child blinded by a doctor. So it is a very serious condition. We have seen over a period of years that the steroid-induced glaucoma prevalence is rising. The number of cases that we saw initially were much less, but now what we see is huge. And that is primarily because of the climatic conditions. There is greater pollution, more VKC in children, more doctors prescribing steroids, and therefore the steroid-induced glaucoma happening. What is most alarming is the fact that about 80% of these children are being given steroids by ophthalmologists. So when we asked parents who gave you steroids, the consistent response was they were prescribed by an ophthalmologist. And we rechecked them. We asked them, did you buy it on your own, or was he a quack? But they said, no, it was an eye doctor who gave me steroids, and that's why I developed the steroid, and that's why they came up to us. And almost like 1/3 of these children were blind when they came to us. So this is probably just the tip of the iceberg. What we are seeing at a tertiary institution is probably very small numbers, but what is happening in the public is probably huge. So it's a big problem. The ophthalmologists who gave steroids to these children failed to check their intraocular pressure or their optic discs. There are no stringent laws in our country who can take these doctors into account. And finally, there's no public awareness. So the problem is rising. What you need to know is that the most common cause of steroid-induced glaucoma is steroids given for VKC. It is inadvertent use. There are ophthalmologists who are also injecting steroids into the tarsal conjunctiva. The child comes with 40, 50 pressures, near total cupping. They have just left the child after that. Most of it occurs in children who are 5 to 18 years of age. The child is rubbing their eyes. The parent is not understanding the fact how he is losing his vision, because there's no way the child can tell what symptoms he's going through. Importantly, you must understand that this potency and the duration with which steroids is directly proportionate to the amount of steroid-induced rise in the intraocular pressure. As I said, symptoms are very minimal, and the signs, if they are not looked for very early, can lead to blindness in these children. But if you look for a child who has got cataract and high pressures, you must always suspect that steroids have been used. How they cause glaucoma, we all know they cause it through the trabecular meshwork. The most common cause is the topical. The topical and the subconjunctival depots of steroids are the most common causes of steroids. Inhalational and oral steroids hardly ever cause steroid-induced glaucoma. They can cause a rise of intraocular pressure, but not so much of glaucoma. The betamethasone and dexamethasone are potent steroids, followed by prednisolone, and can cause a direct rise of intraocular pressure, which can happen in a few days. You see, children are more likely to develop steroid-induced glaucoma than adults. And even among children, the VKC children are more likely to develop a steroid response than a non-VKC child. So if you're giving steroids to a VKC child, you can expect a much higher rise of intraocular pressure than if you were giving any other kind of steroids. If you withdraw these steroids, the systemic steroids, within 3 or 4 months, the IOP comes down. But with the topical or local use of steroids, it may take 9 months, sometimes 12 months, and sometimes it can just go on inadvertently, and it might be very difficult to control the steroid-induced glaucoma. The intraocular pressures can go very high in some children. What is the management? Well, we medically try to manage it. The role of trabeculoplasty is controversial. There are very few studies, but if it can work, it can do wonders. Trabeculectomy and, of course, removing the deposteroid is then, of course, the mode of treatment. Some important questions that are asked are, can topical steroids be used as screening method to exclude patients who are going to have a steroid response? Generally, no, because you can give topical steroids, the patient may not develop a response, but when he is given an injectable steroid, he may develop a huge response. The next question is, what is the shortest time in which IOP can rise following steroid therapy? It can happen as quickly as within a few hours, or it can happen within a few days. But generally, statistically speaking, within 3 to 4 weeks, the steroid response happens. Can it be irreversible? Of course, once the glaucomatous optic neuropathy happens, the disease is irreversible, the vision is gone to a large extent, and it's irretrievable. Can a steroid response occur following filtration surgery? Yes, it's a possibility that even after a filtration surgery that is successful, there is over a period of time scarring, and if steroids have been given, they can cause a rise of intraocular pressure. So that has to be kept into mind. So to conclude, it's important to know that children are more responsive to steroids, and when you are giving steroids to a child, you must be very careful. You have to monitor the intraocular pressure and fundus, and if you cannot monitor them, please don't give them steroids. Steroids are not to be used as a first line of therapy for VKC, as we have better drugs like tacrolimus and other steroid-sparing agents that should always be given as first line. And if you do use steroids for some reason or the other, if child is refractory to everything else, then you must be willing to monitor the child not only for the few months that he's been using steroids, but also for a long period of time. Thanks a lot. Problems people face managing pediatric glaucomas. Yes, there is a very small possibility that they can cause, but not to the same extent as topical or injectable steroids in the eye, yes, but very small. Inhalational steroids and oral steroids can cause steroid-induced glaucoma and should be looked for, but the prevalence is very low. Yes. So it all depends upon the individual response. You see, one patient may not respond to loteprednol, the other patient may have a very high steroid response and may respond much higher to loteprednol or any other steroid agent. Yeah. Well, we continue to give steroids. I mean, I don't know what other people will do. Yeah.
Give a low dose steroid for them. It's
No. If you have got a good filter, it should not fail, and plus, actually, it does help to make the filter better.
prevent
So I think low dose
fibrosis.
steroids is the right this thing, and you don't really want to try something which you have not tried before. So I'll quickly run through this because I don't think.
One more question. Yeah. Tell me. Yeah, so tacrolimus is generally used for the time that the patient is symptomatic, and so we generally tell the patient that it has to be used twice a day, and it can be used on alternate days.
No, how long can we use it?
How
That
long?
is
As
important.
long as the symptoms last. So it may have to be the entire summer that the child may be on tacrolimus, but
Is
then
it safe?
it has to be.
Is it
It
safe?
has been found to be quite safe.
Yeah.
Even for 6 months?
6 months, I would.
Huh?
But VKC doesn't happen in a less than 4-year-old child. We are talking about 5 to, let's say, 15 years of age, yes. But yes, we've given it for 4 months, 5 months, and that could, yeah.
I don't think any side effects have been really reported that way. We ask them to apply it over the upper eyelid. So 2 times a day or once at bedtime, depending upon how severe it is. If somebody has huge papillae in the upper tarsal conjunctiva, then we ask them to apply it over the upper eyelid because the preparation is not an ocular preparation. It's a dermatological preparation.
No,
so
they
we
have
ask
now,
them to apply it.
Sirisha, now we have an ocular preparation also. Yeah.
Now we have it, is it?
But
Okay.
but just a minute, there's a difference of at least 10 times between the two. The ocular preparation is much less concentrated than the dermatological one. So a couple of patients were asking me which one to use.
Yeah.
So you have any?
Ocular, obviously, if there is an ocular available, we would
But
use
the
it.
percentage is much less, and they were not affected.
It
It didn't become effective. So. No. Some of the patients they responded better to the skin one. So this is another
that's another
something
thing that we have
you have to look into that.
Because it's a big problem in our country and we have to solve it. Absolutely.
Yep.
So the next talk is...
What time we have to finish?
We have still
How much time is left?
15, 20 minutes, sir.
15, 20. I'll finish in 5 minutes because this is really not very important. So we'll just go quickly over it. And NVG causes, obviously everybody knows CRVO is one common cause in younger persons. We are not talking of kids. CRAO, BRVO, diabetic, sickle, coats, eels, ROP, PHPV, anterior segment ischemia. The basic idea is wherever there is a hypoxia in the retina, there will be a production of VEGF, and you have to have this VEGF will produce these problems. Iridocyclitis, pseudoexfoliation, melanomas, ROP, yes. But frankly speaking, I don't think anybody in this room would have seen more ROPs than I have seen in my lifetime, because I was working for 2-3 years only on ROP projects, and yet I had to see a single case. And then I went back and thought that why they had written it, and then I got the answer that it was in the baby boomers generation in 40s, when they didn't have the treatment for ROP, when these things used to happen, that they used to develop neovascularization and glaucoma because of this dragging and all that.
Even stage 5 ROPs, generally they can develop...
But that's what I'm telling you. I have seen thousands and thousands of ROPs, but the neovascularization glaucoma is rare. But yes, it's a theoretical possibility, but with good and better treatment, which is happening now. And the moment basically you are doing the basic treatment is to do a laser of the avascular area. And so that is what is happening. Once we do that, it doesn't happen. But if you don't treat it, yes. Coats, yes, there's another thing over there. Classical coats is congenital idiopathic telangiectasia, and diffuse neovascularization of the iris with secondary glaucomas is a possibility. Again, the treatment is same. You have to treat with laser or cryo the telangiectasia. And if the pressures go high, you have to use medications. And I was just going to tell about medications for kids specifically, because I think Viney will also cover the same thing. But very important to understand that beta blockers are good for kids, but be very, very careful. Because if possible, use 0.25. If 0.25 is not available, take 0.5 and dilute it. And if you are not, the point is that they will develop some kind of breathing problems, and we will not realize that they are having breathing problems. And even the kids, even the pediatricians, they don't even know whether that ocular medication is going on. And they will think that, oh, this is okay, there is some khasi jukam here and there. And some of them may end up having chain strokes, breathing, and much, much more problems. So you beta blockers are good for children, but you have to be very, very careful when you use for them. So, and again, these are all case reports, because it was difficult for me to find any major series in which neovascularization and neovascular glaucoma was occurring in small kids. Again, neurofibrinosis type 1 would give rise to these vascular abnormalities, iris neovascularization, and secondary glaucomas. And intracameral avastin along with ablation of retinal vessels, the basics are same everywhere. And even in detachments, uveitis, endo-off, sticklers, retinoschisis, all of which can occur in kids, this can happen. Obviously, in older age groups, carotid occlusive disease, artery ligation, CC fistulas, giant cell arteritis, Takayasu's can all. The neovascularization of the iris begins around the iris, then the pupil, then the peripheral iridotomies. The stages, as somebody else was showing, I think Viney took a beautiful lecture in my course. And as you can see, once the angle is open, it is just that the vessels are growing over, and you can see they are growing over the entire angle and coming above the scleral spur. Right now the angle is open, and it is the good sign, so that if you do something, everything can regress. But once you have a zippered up angle like this, you are in serious trouble. You know that nothing much is going to work. And obviously you can end up with a painful blind eye later. So CRVO, again, same thing, ischemic, non-ischemic, 25% are ischemic, and some of the non-ischemic can also go into it. And angiography is must to detect how much is the avascular area. If it is greater than 10 disc diameters, we have to do something about it. I think I'll skip all this, not really very important. Angiography is important, avastin, PRP, when to do TRAP, DLCP. And anti-VEGFs are given primarily to decrease the macular edema and increase the visual acuity. But basically you have to understand that in cases the anti-VEGF is acting like a small the PRP is acting like a anti-VEGF itself, because you have to ablate the area which is ischemic. Unless you do that, the basic effect will not go away. So the CRBO study, again, the 10 DD, if greater than 10 DD, you have to do it. The rest is not really important. I think we can skip all that. Medical therapy, yeah, that was the important point. Beta blockers, I've already told. Dorzolamide was good, but the kids don't like it because it stings. So brinzolamide has come in, and we are lucky with that. Brimonidine, please do not use brimonidine in less than 6-year-old kids. We have cases of death reported over there, so we do not want, because it travels through the CNS and causes depression of the CNS. And oral estrazolamide, yes, we have seen many a times people for congenital glaucoma give it for some time. You can give it for some time, but the ultimate answer is the surgery. Once the angle is zipped up, you have to think of something else, because whatever you do, even with the PRP, the pressure is not going to drop. And so what we plan, we can do a TRAB, and somebody asked a good question. When should you do when would you give an anti-VEGF, and then when would you do a TRAB? So if you give an anti-VEGF, you can give intracameral or intravitreal, and then wait for 1 day or 2 days, and then you'll see the neovasculature in the iris completely goes, and then you can go ahead and do a TRAB, because not everybody will be able to do a valve, because valves also do well, but not necessarily to do. You can do a TRAB well in these cases. And try with mito will do as well. Obviously, if nothing is available, you may have to go on to cyclodestruction, and I've sent some of the cases to Viney and have done wonderfully well with a localized cyclodestruction. So don't think that everybody who goes for a cyclodestruction will have a thiacal eye, because this is the major misconception currently happening. And last resort, always you may have to do evistration and whatnot. So any unilateral glaucoma, high index of suspicion, check iris, high magnification, check for ischemia in the retina, and the basic idea is find the cause, treat ischemia, and control IOP and inflammation. Thank you.
Thank you, sir. I think another thing, sir, a child with neovascular glaucoma always look for retinoblastoma. So,
Yeah, definitely. Thanks.
Yeah.
That was one very important thing. Sure.
Yeah.
Just a couple of things I would like to share is if you see a child with new vessels on the iris, not necessarily all of them have a neovascular glaucoma. They can happen in primary congenital glaucoma. You have aberrant new vessels that develop. Chronic uveitis that can happen. If you see a CRVO in a small child, we need to be very, very careful. We have had children, homocystinemia, high homocystinemia is one of the causes. You can have subluxated lenses, spherical lenses with high homocystinemia coming with CRVO at the age of 10 and 12 and things like that. And another important cause is insulin-dependent diabetes mellitus. So these are very few causes in children, but if you see a child with neovascular glaucoma or new vessels on the iris, I think we need to be really, really suspicious. RB is a very important differential diagnosis, and that is quite a serious condition. So because we may not be just dealing with the eye, but something more serious systemically.
Yeah.
Blood disgrace.
Blood tumor. Yeah, sure, absolutely. So we'll just conclude this session of glaucoma in young people with a talk on juvenile glaucomas, because they are an important problem in our country. Not so much in the West. We don't know much about it, and also because of the fact that this is a long-term management in a socially productive age group. You know, this is an age group where the lives of the parents, of the children, of the spouse, everybody depends upon this particular earning member of the family. So he is a very important person, and so therefore it's a cost-intensive process, and the economic burden of blindness in juvenile glaucomas is huge. So we are going to tell you something about what we are doing in juvenile glaucomas. It has a male preponderance. It is generally seen to be between 10 to 40 years of age group. The intraocular pressure is not always very high. It can be between 20 and 30 millimeters of mercury also, but a lot of them can have very high intraocular pressures. As far as the inheritance patterns, according to the Western literature, it is primarily autosomal dominant, but in our population it is not so. A lot of them, in fact majority of them, are sporadic. They have dysgenesis of their angle in the form of prominent iris processes, a high iris insertion, an angle which might be absolutely featureless, or to such an extent that it looks like a Barkan's membrane, you know. There could be a combination of this goniodysgenesis, but 1/3 of these patients may have normal appearing angles. So when you look at the gonioscopy and you see a normal angle vis-a-vis if you see dysgenesis of the angle, there is not much of a difference of the clinical features, but those with dysgenesis are generally slightly more severe than those who have normal appearing angles. So here is a patient who has dysgenesis, and both his parents, this is one of the rare pedigrees where both the parents have been affected with glaucoma apart from the child, and you can see that this particular child who has a high iris insertion, the father has an angle which is featureless, the mother has high iris insertion, and he seems to have inherited it from his mother. It can be unilateral also, though majority of them are bilateral. You have to differentiate this type of glaucoma from other glaucomas in this age group, which could be either pigment dispersion, steroid-induced glaucomas, congenital glaucomas presenting at a later age. It could be because of trauma. It could also be because of primary angle closure in a young age, where the angle is convex in configuration. Axon-field rigors, subtle forms can also need to be differentiated. Steroid-induced glaucoma may actually unmask latent juvenile glaucomas, but the steroid-induced glaucomas are generally with very high pressures compared to juvenile and adult onset open-angle glaucomas. Generally, there could be some subtle forms, like in this case, this patient was referred to us with juvenile glaucoma, but actually what you see is he has a congenital ectropion uvea syndrome. So on gonioscopy, he has dysgenesis, but actually the cause of glaucoma was a congenital ectropion uvea syndrome. As far as treatment of juvenile glaucomas is concerned, not all of them require surgery, and majority of them can be on medical therapy for a long period of time. The use of laser trabeculoplasty is controversial. Some studies say it doesn't work in young people, but there are studies now to show that it can work and should be tried before jumping into surgery. As far as surgery is concerned, there are a whole lot of non-filtering surgeries, but trabeculectomy with mitomycin generally is the gold standard, because with these young people you cannot afford to have high pressures for very long, especially if they are one-eyed or they've come with advanced glaucomas. You cannot wait to bring down their pressures with other procedures. As far as selective laser trabeculoplasty, we did a study where we found that there was a certain percentage of patients that did work well with the SLT, and probably so it can be tried in these patients. When you do trabeculectomy, you have to decide whether you want to do it with mitomycin or without mitomycin. Again, a big controversy, because these patients have to live a long life, and if you use mitomycin, it can have long-term problems in these patients. So therefore, a prospective randomized study is actually required to show which is better. So where we did this study and we found that if you use mitomycin, it does lead to low pressures, but at the same time, these low pressures are associated with cataract and hypotony and all these problems. So therefore, when you're looking at young people, you have to judiciously use mitomycin. Probably use low-dose mitomycin, which is a better option. As to the long-term course of these young people is concerned, they do very well. They do much better than the adult-onset open-angle glaucomas. The rates of progression are much less. And if you look at the perimetric progression in these eyes, there is much less than adult-onset open-angle glaucomas. In fact, only 10% actually progress once they are treated. So if you can catch them early, you can treat them early, and you can prevent blindness much more in these young people. So if you look at the perimetric blindness in young people, it's much lower than in adult. And if you look at other causes of adult onset glaucoma, like normal tension glaucomas, exfoliative glaucomas and all, the juvenile glaucomas, when they are treated, have much lower progression rates than the other diseases. So if you can treat them and you can bring down the intraocular pressures, a lot of them can also reverse and become much better than they were before. But the problem is that a lot of them are not picked up, because we only talk of glaucomas above 40 years of age. We don't talk of glaucomas less than 40 years of age. And by the time they come to us, almost 10% are generally bilaterally blind. And there are, of course, socioeconomic reasons for that. Importantly, in modern medicine, we only think of generalizations. We don't talk of individual therapy, and this brings the area of genetics, because the entire glaucoma genes and glaucoma genetics is based on juvenile glaucomas, and the discovery of the glaucoma genes was in this very strict phenotype. And they have found that there are certain genes which are more associated with severe type of glaucoma than the others, right? So basically what we are trying to say here is that they are young people, we don't know much about it, but we still need to find out, and therefore we need to do some more research as far as long-term therapies are concerned and the genetic causation of the disease, especially in our population. So we've been following up these patients, which are almost like 400, 500 now, and a lot of people have helped us over a period of time. Any questions that you have on managing juvenile glaucomas or glaucoma in the youngs? Yes. Yeah, so I don't...
Vinay.
Pardon?
He's
We are
requesting
done?
for it. Yeah.
So, okay, so
We'll discuss
I'll answer
outside.
that
Yeah.
question. Any other questions?
Thank you.